So good afternoon, good evening, wherever you are in the world. It is a fantastic opportunity to present this very innovative session to you. The University of Pennsylvania is running a 2-week conference, the Global Oral Health and Climate Action Conference, parallel and during the main conference that's happening in Belém, Brazil. And the idea of all these sessions is to generate policy recommendations, some action points that will be collated and then feed back into bigger agendas in WHO and also government agendas. So the material coming out of this session will be very much utilized and taken forward. As COP30 presidency said, we need to go from talking to action and implementation. And this, I understand, is really at the heart of this agenda. So without further ado, I will hand back to Valentina and wish you success for this tremendous session that you put together.
Thank you, Julian. Thank you for this opportunity. And I would like to invite our co-chair, Dr. Elin from Norway, to start this presentation and to introduce our speakers for today.
Thank you so much, Valentina, and hello everyone around the world. Today we come together with a shared commitment to climate resilience prevention, the visionary principle and knowledge of what it takes to ensure holistic health, all in the best interest of both children and the planet. As an advocate for children's rights to quality early childhood education and planetary well-being, I'm honored to serve as the moderator for today's webinar with you world-leading experts on a variety of approaches to our webinar on early childhood education as the first line of NCD and climate resilience prevention. My role as a doctor and professor of early childhood pedagogy and as the director of the Kintnow Research Center for Systemic Research on Education for Diversity and Sustainable Futures in Norway has reinforced my belief that in the critical importance of this topic. And I truly believe that the session today will fuel my energy even more. I will remind us all of the WHO UNICEF Lancet Commission, led by Helen Clark, stated in 2020, a future for the world's children. They write, despite dramatic improvements in survival, nutrition, and education over recent decades, today's children face an uncertain future. Climate change, ecological degradation, migration population, conflict, pervasive inequalities, and predatory commercial practices threaten the health and future of children in every country. And in the faces of this polycrisis, which significantly impacts early development, it is essential to create opportunities for bodily and emotional resilience and for joining forces across disciplines, sectors, and national borders. So I'm genuinely excited about the relevance and urgency of our discussions today and a response to this uncertainty as knowledge workers gathered here, becoming global agents for sustainability by sharing our insights and evidence. Because it is evident, beyond any doubt, that early childhood education is vital, not only for children's development and education, but also for fostering long-term resilience in our societies. So, through this webinar, we aim to raise awareness about the significance of early childhood education and emphasize that children's best interest must matter more in policy making and in everyday practices. The Bangkok Declaration from last year expressed the urgent need to intensify efforts to mitigate the substantial health, social, economic, and environmental impact of oral diseases and health systems and societies. So As a response to these concerns, we will explore recent research, insights, and ideas helpful to enhance, protect, and innovate actions, policy, and the pedagogy within the early years institutions, as well as the ecosystemic levels of society, for the supports of child life and holistic nature of development. This encompasses essential aspects such as early cognitive and social growth, foundational learning, responsive care, responsible innovation, nutrition, health, safety, and protection. And I will also mention play, because we must not forget the meaning and joy of life in all the serious concerns. Through our conversations today, we will uncover how empowering children to care for self-protection, care for others and the planet can lay the groundwork for resilient communities and societies. And we will examine a broad range of conditions fostering international collaboration to tackle the threats and challenges facing future generations. We will now travel to the USA and to listen to Dr. Umakanth Katwa from Harvard Medical School in Boston, USA. As I understand, you will bring our attention to functional early detection. And your title is From Reactive Treatment to Functional Early Detection, positioning sleep and oral function as strategic levers for upstream NCD prevention and system level reform. So the floor is yours.
Thank you very much for allowing me to participate in this excellent symposium. So I'm the sleep physician working at Boston, and I will be talking on how can we change the paradigm from reactive treatment and continuity treatment from a course of an early detection. So when you talk about sleep and oral health, the disease I'm going to be talking about is obstructive sleep apnea. So I will take that and try to build a case why this is critical and how we are missing the milestones at multiple levels of a disease which is very prevalent and has a significant impact on the overall health, not only in the childhood, but also of our elderly population. So, so let me start with a case to make my point, and then we'll walk you through some of the things I'm talking about. So there was a 20-year-old male who came to see me with a long-standing history of snoring. He had a history of mouth breathing for a long time, multiple allergies, anxiety, depression, and fluoxetine. He was in the college and he was really struggling through insomnia, sleep disturbances, just not feeling great, brain fog. He even struggled in the high school. He somehow pulled through it, but in the college, he was really struggling. His grades were not great, attention issues, those things happening. If you look at his history, when he was 7 years old, he was diagnosed with severe sleep apnea. He had big adenoids and tonsils, had a surgery. His snoring got better at that time, but he continued to mouth breathe. Then at 10 years of age, he had some allergies because his mouth breathing was persisting. They saw him again. He has regrown adenoids, had another surgery. So there was some partial response to this, but he continued to snore on and off. So his history, he was born at term. He was not breastfed. He had feeding difficulty in the beginning. He preferred soft food when he was a kid. He had a history of chronic mouth breathing, nasal congestion, seasonal allergies. So when you look at him, he was not obese. His craniofacial profile, he had grown beard, but you really look through it. He had a small chin, retrognatic. He had a slightly convex face with the vertical placed mandible in the counterclockwise, with a high arch palate and a narrow maxilla. He had a subtle deviation, very nasal blockage with a turbinate hypertrophy, very crowded airways, tonsils were obviously gone, no tongue tie. So obviously after he came, I referred him to a sleep study. And the sleep study, if you see this blue line, indicates he was awake. He could barely sleep. And he was having these micro sleeps in between here. He was having immediate, each line indicates an apnea and these drops in saturation. So whenever he slept, he he was obstructing, so he could not sleep because he needs to survive to breathe. And the moment he was falling asleep, he was having sleep apnea. Finally, towards the end of the night, his sleep drive was so high, he just slept. And then even though his sleep was very fragmented, he had a multiple apneas. And this is each line indicates the degree of sleep fragmentation. So he had a very significant sleep fragmentation. So he had a very poor sleep quality. He had an apnea index, which is the marker of the severity of the disease, which was 74. Normally should be less than 1 or less than 5 in adults for that matter. Loud snoring. He had mild desaturations, very severe sleep fragmented. His sleep was very, very fragmented. So basically at this point, what are the options for him? You treat him, give him CPAP. The question is, this young man, he's a 20-year-old without any major health issues, non-obese. Why did he end up on a path of a severe sleep apnea affecting his life up until now? And then we are recommending a treatment which we typically recommend in much older population. So what is the future? Like, how long he's going to use CPAP? Is it for the rest of his life? So let's go back and try to understand what is sleep apnea. Sleep apnea is, or a sleep disorder breathing is a very highly heterogeneous systemic chronic inflammatory disorder of dysfunctional breathing during sleep. There are recurrent episodes of partial or complete airway obstructions. So if you do, these are the main criteria for children. They have to have snoring, they have to have a labored breathing, they can have daytime sleepiness, tiredness, fatigue, learning difficulties, neurocognitive issues, all those things. And sometimes parents bring you a video recording of the child sleeping. And if you can see this child is breathing through the mouth, you can have this paradoxical breathing where the chest wall is moving in opposite direction to the abdomen. This is a classic obstructive sleep apnea breathing pattern. So parents bring, and it's very diagnostic of a severe sleep apnea. And if you do sleep study, they have a sleep apnea on the sleep study. So why should we care about sleep apnea in children? And what are the consequences? Right? I think just Karen talked about the importance of sleep and how it develops and what are the mechanism of sleeps and how it can impact the overall health. So basically, there are 4 things happening because of obstructed breathing. You can have an intermittent drop in saturation. You saw in the sleep study. There can be elevated carbon dioxide because you're not able to take a bigger breath. Your sleep can be very fragmented. You saw that on the sleep study. And you're working hard to breathe through the narrow airway. You increase the respiratory effort. So you are in an autonomic drive during sleep. So sleep should be more of a parasympathetic pattern where everything is calmed down, you're breathing comfortably, but you're in a stress mode because of this struggle breathing with an obstructive airway. So because of that, there is more autonomic surges. There is blood pressure dysregulation during the night. There is endothelial dysfunction. There can be dyslipidemia because of the metabolic dysregulations, endocrine issues such as insulin resistance. You can also have a significant impact on the neurocognition because of the fragmented sleep in children, which basically includes excessive daytime sleepiness, attention issues, poor memory, poor concentrations, and some children can also have nocturnal analysis. Right, and you can look at these things. A patient who can have a healthy person, when he can develop sleep apnea and he can throw in obesity, he can go in multiple directions regarding his comorbidities. And these are all the chronic diseases we are talking about. These diseases affects the quality of the life, the healthcare burden, and overall health of a patient. And majority of people are struggling to treat them. And these, to some extent, we can minimize or delay as much as possible, like hypertension, atherosclerosis, diabetes, attention issues in children, anxiety, stress management, anger issues, and drowsy driving. You can name it, and it has an impact because of sleep disturbances. So let's talk about 6 different presentations of sleep apnea at a 6 different age group. So we have a 2-year-old male present with snoring and mouth breathing. We have another 8-year-old male continues with ADHD, snoring, mouth breathing, and he has malocclusion, crowded teeth. We have a 14-year-old boy who struggles in school, high ash palate and small mandible. And we have a 26-year-old female, anxiety, fatigue, depression, tired, and a 42-year-old male with hypertension, OSA, divorced. 69-year-old male with memory issue, dementia, hypertension, and those things. So you can have a sleep apnea with a variety of presentations. And we see these patients in and out. And let's take this and see how they land where they land in things. So if you look at the burden of sleep apnea, this was a study published in Lancet. There are about 1 billion people in the world who have at least mild to severe degree of sleep apnea in 30 to 69-year age group. And if you look at the moderate to severe, meaning those are the people who you need to treat, about 500 million people are affected. And we don't have enough sleep trained people or the pediatricians or the primary care around the world who are aware of the sleep problems. Even in the most developed countries, not uniformly everybody gets screened unless they have a significant symptoms and they go to the doctor. I think that may change with the advent of the technology, wearable technologies, where people start monitoring their health. They can come at an earlier date. And every country in the world have risk of sleep apnea, whether the population is obese or non-obese, because of the other factors can play a role. So if you look at the factors affecting sleep disorder breathing, if you really spread around, that can be right from your genetics and epigenetics, which can frame you the way your airway develops. It can be some prenatal factors, some gestational factors, some postnatal factors, infancy, lifestyle during the childhood and adulthood, and ultimately the environment is also playing a significant role. With the increase in pollution, climate change, and global warming, there has been impact on the quality of the air we breathe and the sleep stability, because warm temperature fragments your sleep and you go into lighter stages of sleep, and people are sleep deprived more in the warmer climate when they're sleeping compared to the populations who have a relatively stable climate. So the genetic factors, classically in sleep apnea, they don't follow the Mendelian inheritance. So if somebody has an OSA, the combination of the genetic factors and the epigenetic modifications with the environmental exposure we talked about, such as intermittent hypoxia, can further influence the disease expression and the endotypes and the severity of sleep apnea. So basically, if somebody has sleep apnea, this hypoxia can modify your epigenetic factors, and some of the symptoms and expression of the disease can be accelerated depending on, like, metabolic syndrome can be accelerated or hypertension can be unmasked. So having that will unmask some of the disease phenotypes. Chronic hypoxia can also lead to epigenetic modifications, particularly we are talking about in the fetus, and histone modifications can also express into various inflammatory stress response, sympathetic activation, metabolic pathway, and ultimately a combination of what you're designed genetically to be and what your epigenetics are modifying the gene itself because of your intermittent hypoxia or stress response during sleep can manifest how you present with sleep apnea. There are various presentations. Some have mild symptoms or minimal symptoms, and some can have a significant symptoms for the same degree of sleep apnea on a sleep study. If you look at the gestation sleep apnea, we're talking about sleep apnea during pregnancy. And this is an important aspect because this ties into what happens later in life. So about 10 to 20% of the pregnant women develop sleep apnea during pregnancy who never had sleep apnea to begin with. The highest vulnerability is during the 3rd trimester. So what does sleep apnea in a mother has effect on the pregnancy? If you look at this sleep study, this is the sleep study where the patient sleeps. This line indicates the patient was before the treatment, and this is your oxygen saturation. You see the patient sleeps, and each line, pink and red line, indicates an apnea. They're nearly continuous apnea, and the brain is waking up continuously. Each line indicates an awakenings. The patient was snoring here. You see the oxygen is, this is 70. I don't know, you can see this is 100%. The oxygen was going into the 70s when the patient was sleeping. Imagine this stress response and the intermittent hypoxia, making the hypoxic condition of the fetus even worse from night to night basis for the entire duration of the particularly 3rd trimester. So what happens because of this is the mother is at a higher risk of developing preeclampsia, also risk for developing preterm labor, insulin resistance, and frankly, gestation diabetes in some patients. There's the risk of C-section increases because the fetal activity and the fetal distress can increase because of sleep apnea. And there is also possibility of fetal growth restriction. And when we treat these patients with CPAP, this is where you start treating CPAP. You can see the oxygen with increasing pressure completely normalizes. The patient starts getting into this red is the REM sleep. Initially, they didn't have REM sleep. and the apneas, as you increase the pressure, will go away. So you can literally treat that, provided that you identify and prevent the damage it can cause to the fetus. So, so ultimately, what are the maternal sleep apnea? What are the effect of the maternal sleep apnea on the fetus? And if you look at this video here, this is a baby who is doing the sucking, and actually sucking the thumb in utero. This is an ultrasound image. You can see the tongue and the motion of the tongue where the baby is actually sucking. And this is an important mechanism for the baby's tongue to develop, maxilla to develop, and jaw to develop. If the baby does not do the sucking movements, whether with thumb sucking or without the thumb sucking, because the baby is swallowing the amniotic fluid, it can ultimately affect the craniofacial development, swallowing function, and these are the babies who subsequently can present with dysphagia, speech issues, or trouble breathing issues. And that second swallowing mechanism can be affected by maternal sleep apnea because of the intermittent hypoxia and the stress response. It can also affect the fetal gene expression we were talking earlier. Like we saw the second swallowing, it can impair that mechanism. Because the second swallowing is not happening, the jaw development, which is this exercising effect on the jaw, can be affected. It can also affect the fetal breathing when the fetus is trying to breathe and learn how to breathe when the baby comes out. So these babies are at high risk of developing certain apneas. It can impair the muscle and the myofunctional harmony in the baby, and ultimately lead, if it is significant enough, fetal programming and organogenesis in particular system. Not all the babies are prone for that, but certain babies are high risk. So it can have a systemic effect on the baby if the significant sleep apnea in mother is left untreated for a long duration of time. So if you look at the craniofacial development, right, and you can see the baby here has an inferior facial angle, which is on the low side. If you see a baby with the chin already small in utero, you can be rest assured that the baby is going to be born with a smaller chin who is at a high risk of developing sleep apnea subsequently. And there are a lot of factors which determine the jaw and the maxilla and the craniofacial growth. Obviously, your genetics play a big role. The biggest role on a day-to-day basis in the fetus is because of the suck-swallow breathing mechanism. And ultimately, your brain growth and almost the craniofacial growth, about 60% is complete by 6 years of age. So if you don't really recognize them pretty early on, you may miss them and you may be not able to completely recover the symptoms. And these are the stimulus for the craniofacial growth, which we talked about. After birth, the breathing is important. Babies have to breathe through the nose. They're designed to breathe through the nose because it affects the craniofacial growth of the baby. It also stimulates the respiration when you're breathing through the nose. It also helps the diaphragmatic contractions. If you breathe through the mouth, your respiration is shallow. It helps in sinus and maxillary development. And if you look at the patients who are mouth breathers, are chronic nasal breathers, they are not breathing through the nose. They can have maxillary narrowing, narrow nose, narrow upper jaw, and they can have malpositioned canine teeth. So the jaw of the upper jaw becomes smaller. So the teeth may not have enough space for them to grow. So you can have developed the teeth coming all over the place. So that's called malocclusion. Your daytime breathing pattern can also affect the nighttime breathing pattern. So if you're chronically mouth breathing, because your mouth is open, both awake and asleep, your jaw development is affected. And because of that, you develop a narrow jaw, abnormal teeth, your airway tends to get blocked and obstructed. And ultimately, from an intermittent mouth breather, you become a chronic mouth breather. From a chronic mouth breather, you can develop this craniofacial dysmorphism. And because of the craniofacial dysmorphism, you develop sleep apnea. So a simple mouth breathing can ultimately, untreated over a period of time, can result in sleep apnea. And now you are not able to breathe through the nose because you have structurally abnormal skeletal development. And these, again, without going into the details, these blue highlighted are the classic pathophysiological factors which affect sleep apnea in adults. If you really look at what's happening early in life, each and every aspect of the pathophysiology of sleep apnea in adults can trace back their origin in some point and form and shape that they were developing the disordered breathing. It was left untreated to the point that they landed up with the significant issues. Not all the patients have all these things, but some patients have a combination of these things, which leads to sleep apnea. So finally, again, the same thing we were talking about. These were the same factors we discussed earlier. So now the model is what we're going to do about it. So the preventive airway health model in the newborn screening tools. So airway focus screening in the well baby visit is an important aspect to early recognize these things, particularly in the pediatrician and the dental offices. One should advocate strongly for the breastfeeding. And if there is a trouble, you should have a lactation support. And the breastfeeding is not necessarily just for nutrition. Nutrition is one aspect of the breastfeeding. Breastfeeding, I think you really heard the previous speakers, that it also has impact on a lot of things on top of other things, neurocognitive issues and maturation issues and bonding issues and neurodevelopmental issues. It also has an impact on the craniofacial development. If that is lacking, people are breastfeeding by expressing the milk and giving by the bottle, which will have consequently some of the craniofacial dysfunction which we can develop. People are using pacifiers, and the wrong pacifier can actually lead to abnormal craniofacial development. I think with the new technology and AI, we can actually scan. There are pacifiers which actually helps to expand the maxilla, so it can help you. So prescription grade pacifiers can also be recommended. I think there is some work happening in that area rather than just giving a pacifier for a baby, and that should not be used for more than a year. Basically, the American Academy of Pediatrics recommends these in the prevention of SIDS because there is a good data. It helps with the respiratory maturation. So weaning, people are trying a lot of soft diet that discourages chewing. So we should encourage them to eat harder like food, address the mouth breathing quickly. You should quickly screen them for growth trajectory and early interventions. And these are some of the red flags, what you can see. If there's a premature infant, definitely high risk of sleep-disordered breathing. If the baby has an open mouth posture, not getting better, you should look for that. Low facial muscle tones. If there are tongue ties, we should address that. If there are crowded airways, we should definitely take care of that. That could be a red sign that the airway may be compromised. Low tongue posture, this is a hard palate. If your tongue is sitting on the roof of the palate, the jaw is wider. As the tongue goes down, you can see how the distance between the canines, the molars in the upper jaw can be narrow, and that leads to high arch palate, and these patients are at a high risk of developing sleep apnea. So this is how it looks, and snoring. So these red flags at early age can be picked up and actually try to correct them. Early intervention strategies. So typically in the medical field, the modern medicine, we don't treat until you develop symptoms. We treat once the problem happens. We are not proactive when we see the signs. So we should not wait until they develop symptoms when you know the risk factors are there. Lactation support, speech feeding therapy is important. Nasal hygiene is extremely important, particularly because of the rise in the allergies. If there is a low muscle tone, nasal congestion, you should address them. Tether tissues, we should fix them. In patients who are already having some dysmorphism at an early on, some functional appliances or early interceptive orthodontics can help them to correct some of the orthodontic issues. The goal of the screening should be optimize the airways and the breathing. You can improve by that in early intervention, improve craniofacial harmony and myofunctional balance. You can also reduce the risk of sleep-disordered breathing, which I'm talking about is improve the airway, improve the muscle tone so the airways are not floppy and the airways are not narrow. This ultimately gives stable sleep because of stable breathing, has a long-term and impact on the neurodevelopmental outcomes in these patients. So an integrative airway team approach is very, very critical for a sleep perspective. So if you look at all these 6 patients, so all the 6 patients can literally present with the same presentations, and it could be same patients. It could be the same patients who was at 2 years old having these symptoms, was misdiagnosed. Then he came at 8 years of old, he developed these symptoms. Then he was 14 years old, he was struggling and he got some other treatment or tonsils were taken out later. And then he continued to struggle with his life because his life got busy, he got anxious, got married, life. He continued to struggle with this and then becomes 40 addressing these issues. And ultimately at 67 or at a time of retirement, this person can already have an early onset dementia because all this time, these symptoms were lack of, they were not addressed properly or they were not seen in continuum because every time the physician changes, every time you're not able to connect the dot. So this is what the same patients the same patient what you saw earlier can present all throughout the life from 2 years age to 67 years of age. So we had missed opportunities during pregnancy. If there was an apnea, we did not address that. We had missed opportunities during infancy, which we did not address. In toddler age group during weaning, we were not concerned about the diet. Mouth breathing was not addressed. There were concerns in teenagers we missed. concerns in young women who will become pregnant, who are not addressed, and ultimately in adulthood, by the time they reach there, we feel sometimes the symptoms have already reached to a point of causing significant diseases that we are only treating at that time. There's not much we can do for prevention. So finally, if you look at the Barker's hypothesis in the context of OSA, I think people may be aware of this one. So this one, in the context of OSA, the Barker hypothesis is relevant because intermittent and chronic hypoxia and sleep disturbances because of sleep apnea in mother leads to fetal exposure that impairs craniofacial growth, airway maldevelopment, and metabolic regulation, and later increases the susceptibility of OSA in the patients and is associated with comorbidities in adulthood. If you look at these events here, right, in pregnancy, you can have hypoxia, fragmentation, and intrathoracic swings. It can cause oxidative stress, increased sympathetic nervous system activation, hypothalamic pituitary adrenal glands activation, and increased cardiac preload. So these patients can subtly, initially can have high blood pressure, metabolic dysregulation, systemic inflammation, endothelial dysregulation, and ultimately end result can be hypertension, diabetes, coronary artery disease, cerebral vascular disease, arrhythmias, and heart failure. Sudden death are also very common in untreated sleep apnea, which happen typically early in the morning. So I think we need to have a paradigm shift from a symptom-based screening, diagnosis, and treatment to prevention, early intervention, and phenotype-based precision therapy. Prevention can start right from pregnancy, early infancy. If you see any signs, do an early intervention. Don't wait till the symptoms develop. And if somebody has symptoms already developed coming late into the game, we should be focusing on the precision-based therapy for these patients. So we can plan during pregnancy, fetal monitoring, avoid prematurity to, if possible, C-section, strongly encourage breastfeeding, dietary practices. We can also monitor the airway during infancy in preschool and school. Sometimes the preschool can be a good place for these people to actually, the nurse or the healthcare people can also pick up and bring to the attention of the parents. On the broader scope, we need public awareness about sleep and breathing. Newborn screening programs can be initiated to see for any red flags. Reduction of the pollution is a big term goal, but ultimately that's another impact which can have in the quality of the life and the development of the airway. So finally, the take-home messages are, early risk factors can affect structure-function relationship, particularly craniofacial dysmorphism. They set up for the airway problems and sleep apnea later in life. By the time the symptoms develop, or the patient come to you with the real symptoms, structure morphology has already established and changes have already happened. Delayed or suboptimum treatment of PEDS OSA or infant sleep apnea or mistreatment or not treatment at all can predispose to development of the adult sleep apnea and discuss and all the things I discussed about the long-term health consequences in adults. So treatment of OSA should include rehabilitation of the airway and correcting the breathing pattern, which may start right during pregnancy, infancy, early childhood, all throughout the life. And life has to be a continuum to pick up at every point where we have a potential to evaluate and diagnose them. Thank you.
Oh, thank you so much, Dr. Umakanth. This was really informative. I think that I agree with you that this should be out in the public and to giving especially awareness for parents and also, yeah, early childhood. So thank you.